Chapter 8, Communication and the Nurse-Patient Relationship. These are the theory objectives for this section of the chapter. So, communication to nursing is just like areas to life. One cannot exist without the other. So, the relationships that are developed with the patient exist within the context of the communication process. Communication is the glue that holds together the nursing process. The absence of effective communication can lead to faulty data collection, which in turn leads to incorrect nursing diagnoses and the development of a care plan which will not meet the patient's needs. Furthermore, communication extends beyond the nurse-patient interactions. It also occurs between various um, members of the healthcare team, and it serves as a tool for care coordination. So if members of the healthcare team are not communicating appropriately, then mistakes and things can happen within patient care, and then we don't have our optimal uh, level of functioning for our patient if we're not communicating appropriately. If the doctor doesn't communicate to the nurse that order needs to be changed, then that order doesn't get implemented. If the nurse doesn't communicate to the doctor that a patient's situation is declining, then the doctor doesn't know they need to order something, and so on and so forth with all members of the healthcare team. We have to be able to communicate properly. So there's several components to the communication process. You have the sender, who is the person that's constructing or sending the message. You also have the message itself, and that message can be verbal or it can be nonverbal. Um, and so, and we're going to talk about here shortly about the difference between the two. And then you have the receiver, who's the person that's actually receiving the message. They have to interpret that message, and then you have feedback or response from the receiver based on how they interpreted that information that you sent them. Okay, so just like we said in the previous slide, we have verbal and nonverbal communication. A good majority of what we're saying and how we're communicating is nonverbal. So our verbal communication is your spoken or your written words, and your nonverbal communication are messages that are communicated by uh, your different expressions. So your posture, your facial expression, your voice tone, all those things. You ever heard of it's not always what you say, but how you say it? Your nonverbal communication can say a lot about um, what you're actually thinking or feeling. So nonverbal communication, that could be gestures that you do. It could be your body posture. Are you standing with your arms crossed? Are you, um, you know, sitting? Are you sitting, leaning forward as if you're actually listening to the person? Does that says you're listening to the person? So what's your body posture? What gestures are you using? Intonation. Intonation is the rise and fall of your voice when you're speaking. So does it appear as if you're yelling at the person or not? Just your general appearance. What's your general appearance like? So all these things can communicate different things um, to whoever it is you're speaking to. And so sometimes there could be times when our verbal and nonverbal communication are incongruent. Incongruent meaning they don't agree with one another. For example, if um, your patient is saying, "No, I'm not in any pain," but yet they're crying and guarding their abdomen, that could say to you, yes, they are in pain, although they're verbally saying they're not in pain. That would be incongruent when my verbal doesn't match my nonverbal. So we want to look at, we want to listen to what they're saying, but we also want to watch their body language and their nonverbal communication as well when we're communicating with our patients. We also have to keep in mind that when we're communicating with various individuals, a lot of different things can impact the way a person communicates, and we can't necessarily take offense to these things. For example, cultural differences. So, in our culture, we teach you to maintain eye contact, right? But in some cultures, maintaining eye contact can be disrespectful, and so you don't want to judge a person if they don't want to maintain eye contact with you because their culture views it as being disrespectful. Um, Also, personal space is different um, for different cultures when they're communicating. Some cultures, the 6 feet is normal when we're communicating. I need my space. Whereas other cultures, they want to be right up in your face when they're communicating. So we got to be cognizant of that when we're communicating with other individuals. Sometimes, um, we're nodding our head. When we nod our head, that means yes. But in other cultures, it might not mean yes. So we have to keep that um, in mind as well. Some cultures, older adults may not want um, younger adults or younger people to educate them or things like that. Religious beliefs can be different among different cultures. So we got to keep these things in mind as we're communicating with people of different cultures that they may have some different ways of communicating. So, some other things that can impact the way an individual communicates may be their past experiences. Different experiences can, impact. So, we already talked about our cultural values. Your level of education can impact your the way you communicate. Are you familiar with a topic? If you're not familiar with a topic, then maybe um, you're not as vocal on the topic. Your occupational. Um, your occupation or your previous life experiences. So, for example, when we're talking about your life experiences, your education, your occupation, things like that. For example, a nurse is likely to have more medical training than their patient, right? So, when you're communicating with your patient, and we're not even talking about degrees and things like that because a lawyer may not even understand some of the medical knowledge that a nurse may have, right? A lawyer is educated, but they're not educated in the healthcare field or medical field. So when we're communicating with our patients, don't use a lot of medical jargon because your patients that are not necessarily in healthcare may not understand that information. And also, even if they are in healthcare, maybe they're in a different field, and so they still don't understand your language in the field that you're in. So either way, we're not going to use a lot of medical jargon when we're talking to our patients. We're going to, just use plain English, make it plain, to our patients or whatnot when we're communicating with them. Okay, other things that can impact communication. A person's emotions or their mood can impact how well they communicate. If a person is anxious or they're upset, they just got some bad news, or they just found out they had a terminal diagnosis, or they're depressed or whatnot, they're not going to communicate as effectively, and so that's probably not the best time to try to teach your patient something because they're not going to hear what you're saying, or understand or comprehend what you're saying if their mind frame is not in the appropriate state to take in what you're saying. So be mindful of that people that are anxious, they're depressed, they're upset, um, will not be communicating in the same manner. Your body language, you want to make sure your body language projects um, uh, a way that shows that you're open to listening to your patient. And that you have an accepting attitude towards your patient. So be present, be focused when you're listening to your patient. Show them that you're an advocate for them. Be attentive. Don't be judgmental. We want to be non-judgmental, no matter what the issue may be. Don't take things personal. If they are upset and lashing out or whatnot, don't take it personal. Um, that is towards you. If I just got a terminal diagnosis, it's nothing against you. I'm just upset, at the fact that, I just got this terminal diagnosis or depressed about it. So don't take things personal that they may be, if they are showing anger or things like that. Just again, be non-judgmental. Let them know that you're there for them. Have that open attitude, towards your patient. Okay, active listening. Active listening helps to build a trusting relationship with your patient. You want to show your patient that you're there for them. You're hearing what they're saying. So listen to what the patient is saying. Don't stereotype or assume what the response will be or respond to the patient based on the stereotypes. So don't sit there trying to think of what you want to say while they're talking. Don't give an automatic response. Just listen to what they're saying and to show them that you're actually listening to what they're saying. Some nonverbal things that you can do to show them you're actively listening. Maybe you're leaning forward. You're focused on your patient's face. So you're maintaining eye contact, except in cases where we talked about where the culture feels it's disrespectful. But other than that, you should be maintaining eye contact, not staring, but having that eye contact, nodding slightly to let them know you're listening. Giving cues like, okay, saying something like that, or maintaining an open body posture so you're not sitting there with your arms closed, or that shows that you're closed off to what they have to say. um, and maybe restate what they said or clarify what they said. So what I hear you saying is XYZ, just to kind of show that you're actually listening and then making sure you're getting clarification as to what they're actually saying. You want to make sure you keep the conversation on the topic at hand. Sometimes, especially when you've built up a good relationship or a good rapport with your patient, um, they want to go off topic and, tell you about the family and the grandkids and, tell you all about, different things or whatnot. And so you want to keep it focused on the topic at hand. So to make sure we're focusing, you can say something like, um, we'll come back to that later. But right now, I need to know about XYZ, or I think we were talking about, right? So let them know, you're interested in what they have to say, but right now, let's focus on this pain that you're having, or this issue that you're having. So make sure we keep it focused, keep the communication focused on the topic at hand that we need to focus on at that time. Okay, so there are times that you may need to adjust your communication style. For example, if we have a patient that's a slow communicator or they're calm communicator, maybe we got to adjust our pace, or think about what if I had a patient that had a stroke and has difficulty communicating. So we may have to um, adjust even more. Maybe we got to use communication boards or using gestures even more so or whatnot. So we got to think about our patient. Maybe we got a patient that's hard of hearing, or something like that. So think about our patient and what's going on with our patient, or even our coworkers. Maybe we have to adjust our communication style based on, um, you know, uh, the way they communicate or things like that. So there are times when we may need to adjust our communication style based on the situation and what's going on. Okay, so therapeutic communication is a purposeful communication that's used to produce an established outcome, typically developing a therapeutic relationship with your patient or trusting relationship, building trust with your patient. So therapeutic communication should be non-judgmental and it should be patient-centered. So it encompasses being trustful, honest, maintaining privacy and confidentiality, respect, courtesy, empathy are all things we should think of when we're thinking about therapeutic communication. Now, in your book, there's a tables 8.1 that discusses some various therapeutic communication techniques that you can use to develop a therapeutic relationship with your patient. For example, if we're talking about general leads, so general leads are things you use to encourage your patient to continue to elaborate. So you say, go on, I see, please continue, things like that. That encourages them to continue to elaborate. We want to use open-ended questions or statements. Open-ended questions are things that are going to allow our patient to elaborate on the topic versus a closed-ended question. A closed-ended question, I'm looking for a specific answer. For example, I say, where's your pain? Right leg. That's a closed-ended question because I'm looking for one answer. Or I'm asking a question that's going to give me a yes, no response. So those are closed-ended questions. Therapeutic communication is going to be something that's open-ended. And so that open-ended is going to allow them to elaborate. For example, the example your book uses, tell me more about that feeling. Now they can elaborate more on the topic. Offering yourself, I'm here to listen. Restatement. Some of these we've discussed already. Restating, what the patient says, right? So that lets them know that you're listening. And so, it encourages them to continue communicating because I'm actively listening to what you're saying. Reflecting on what the patient has said. Seek clarification. You know, um, so for example, the book uses um, having my little girl come to visit me was so hard. I'm so upset. The nurse says, something about your daughter's visit upset you? So clarifying, right? Focusing, encouraging them to elaborate, giving them information, looking at alternatives. Silence can be a therapeutic communication. Um, so it just gives them time to gather their thoughts, right? And so you don't have to just keep talking all the time. Um, allow that patient to time to think about, what's going on, what's been said, and things like that. And summarizing, all these are considered therapeutic communication techniques that you can use with your patient to help build trust. If we don't build a trusting relationship with our patient, then they're not going to want to communicate with us. If they don't want to communicate with us, then we can't find out all the data we need or gather all the data we need to make to have a thorough assessment for our patient. We want them to trust us and open up to us and let us know what's going on or what issues that they may be having. Okay, so a block or barrier to effective communication is something that impairs the transmission of the message or receiving of the message from the nurse or the patient on either end. Um, So a goal of therapeutic communication is to avoid these blocks or barriers to communication. So avoiding barriers to communication can be challenging since um, sometimes many of them are just natural responses most people use in conversation. So in your book on table 8.3, there's some blocks to effective communication that we want to look at. Changing the subject that deprives the patient of the chance to be able to verbalize their concerns. And it also shows them that you're telling them, I'm not listening, I'm not interested in what you have to say. What I have to say is more important. Giving false reassurance. You never want to give false reassurance. For example, the book uses the example, I'm sure it will turn out fine. You don't need to worry. That's false reassurance. You telling them, oh, that lab value will be fine, I'm sure. And then it comes back not fine. And then now they're angry at you. You said it was going to be all right. And so, it also negates the patient's feelings and may give them false hope. Being judgmental, you don't want to use judgmental responses. You don't want to be judgmental to the patient, okay? Defensive, you don't have to be defensive, right? Because remember, I told you, you don't want to take things personal. Ask probing questions. You don't want to probe, right? That pries into the patient's motives, and it invades their privacy. For example, the book uses where were you um, that oh why were you there at that hour, or why did you intend to prove, what did you intend to prove? Or using cliches, that's a block to effective communication. Oh, cheer up, you'll be home soon, this won't hurt, everybody goes through this. These are cliches. Giving advice, right? Don't you you're not giving advice about, oh, I think you should do this, or if I were you, I would do this, right? We're not giving advice. And then inattentive listening, right? You want to be attentive in your listening. You shouldn't be watching the clock. You shouldn't be standing at the door with your hand on the doorknob, ready to go, or whatnot. Show that all those things that we talked about, being attentive. You want to make sure you're being attentive to your patient and listening to what they have to say. If they feel like you're in a rush and don't have time for them, then they're not going to want to open up to you. Also, you don't want to ask why questions. Anything that starts with a why question, you don't want to ask why. That is as if you're attacking your patient. If you say why, why did you do this? Why were you here? Why are you using this diet? That's as if you're attacking the patient. So anything that starts with why, you don't want to ask your patient why questions. Those are considered non-therapeutic. Andy is having difficulty communicating with his patient. His patient barely understands English, is highly anxious about being hospitalized, and doesn't look at Andy when he is speaking. Which four factors affect communication? So your answer is one. Cultural differences, past experiences, emotions, and attitude. There are four factors that affect communication. They are cultural differences, past experiences, their attitudes, emotions, and moods. So style and focusing are a type of communication style. And age might be considered a past experience, but not um, not a category by itself. And tone of voice is considered a characteristic of a mood, not a category. Holly is trying to encourage her patient to elaborate rather than replying in short one or two words answers. Her patient relates to Holly that she doesn't feel safe at home. Holly replies, "Would you tell me more about this?" This is an example of what type of therapeutic communication technique. The answer is 3, open-ended questions. So remember, open-ended questions create an inviting atmosphere for sharing thoughts and feelings and concerns. And so you want to encourage elaboration um, in a therapeutic communication style. Emily's patient is very nervous about the surgery. She is having a breast biopsy. Emily tells her patient, "I'm sure it will turn out fine. You don't need to worry." This is an example of which communication block. The answer is 2, giving false reassurance. So this response of false reassurance negates the patient's feelings and may give false hope, which, if things turn out differently, can destroy the trust in the nurse. So these are the theory objectives for the next section. And these are the clinical objectives for the next section. So using um, therapeutic communication to interview our patient, it can be difficult for some nurses. Not every nurse feels comfortable, especially as a new nurse or even a nursing student may not feel comfortable talking to patients and developing a therapeutic relationship with a patient. So a couple of things you can do when you're going to be interviewing a patient or communicating with a patient to help build a trusting relationship with that patient. Definitely want to introduce yourself. Ask the patient how he or she wants to be addressed. Never address a patient as honey or sweetie or dear or anything like that. Ask them how they want to be addressed. Include the patient's family if the patient wants their family included. Explain the purpose of the interview. Explain what's going on. Explain how the information is going to be used. Um, Make sure you provide privacy. Make sure there's not going to be any interruptions. You know, doctors aren't going to be making their rounds in the next 10 minutes, or they're not having, a bunch of visitors coming in a few minutes or whatever. Make sure the patient is comfortable. Eliminate noise, turn out the TV, close the door, so that we don't get the noise from the halls or whatnot. Using empathy. So you need to know the difference between sympathy and empathy. Sympathy focuses on the nurse's feelings about the client's situation, whereas empathy allows the nurse to accept the patient's situation and deals with the issues at hand. So we're going to be empathetic. We're going to be non-judgmental. Maintain hope. People are allowed to still have hope, but we're not providing false reassurance and telling them, "Oh, this is going to be okay," because we don't know if it's going to be okay. But you don't have to destroy their hope if they still have hope about the situation or whatnot. Okay, so sometimes, like we said, remember we said we may have to adjust our communication style depending on the situation. Sometimes we have individuals that may be hearing impaired, right? So we got to think about how we're going to adjust our communication style with these individuals. You want to just speak clearly. We don't have to shout or yell at the person, um, but speak clearly, slowly. You want to face the person because a lot of times people with hearing impairment learn how to read lips. So make sure you're facing the person when you're speaking to them. Get their attention before you start talking. Don't just start talking. Make sure you have their attention first. Want to make sure you maintain a good distance. Watch their nonverbal feedback. Also, using short sentences. We're not gonna use a long sentence and expect them to understand everything that we said. So just short, simple sentences. Um, and paraphrase what they say for clarification and give that person time to respond as well. I said, okay, so communicating with aphasic patients. What is aphasia? Aphasia is loss of the ability to be able to understand or express speech. So you have expressive aphasia, where you can't express what it is, what you want to say, or receptive aphasia, where you can't understand what someone else is saying. So again, we will need to communicate or need to adjust our communication strategy when we're communicating with these individuals. There's a nice box in your book, box 8.1, that discusses how to communicate with an aphasic person. You want to make sure you have the person's attention before you start. Make the environment relaxed and quiet. Assume the patient can understand what is heard unless deafness has been diagnosed. Speak to the patient as an adult. You don't want to speak to them as if they're a child or if they're mentally incompetent. Talk to the patient. Don't talk to someone else in the room about the patient. Include the patient in the group conversation. Give directions with short phrases, simple terms. You may need to use gestures to, further express what you're trying to say. Um, Try to, just do simple questions, yes, no responses. Same thing with our hearing impaired. We're going to yes, no responses if at all possible. Ask questions one at a time. We're not going to ask questions one after the other or whatnot. You might need to repeat something. Use the same words if you do. Use your body language, use your gestures to try to help further elaborate on what you're trying to say. Allow the person to speak at the time, one at a speak. Okay, so we've talked about with our older adults as well, we may need to adjust our communication styles as well. Now, just because I get older, it doesn't mean I'm going to be hearing impaired or have visual disturbances, but that is a good possibility that I could have some of these issues. So, if I do have a older adult that has some type of hearing impairment, first determine do they wear hearing aids? If they do wear the hearing aids, make sure they have their hearing aids in. Make sure the hearing aids are turned on. Make sure the batteries are in place and are working appropriately. Just like with our hearing impaired patient, we want to face the patient because sometimes they learn how to read lips if they do have some type of hearing deficits. If it's one ear that's worse than the other, then position yourself on the side with the better hearing so that they can hear you. Again, we're not going to yell and scream at them. We're going to speak clearly in a normal voice. Touch their shoulder or whatever to get their attention before you start talking. If they wear glasses, make sure they have their glasses on. Also, maybe when we're communicating, if we're communicating in writing, maybe they need large print or things like this. So we need to keep these things in mind when we're talking about our older adults that have some type of hearing or visual deficits as well. Give them time to respond. Ask one question at a time. Or whatnot, and watch their verbal and nonverbal feedback as well. Okay, so again, when communicating with children, we also may need to adjust our communication styles with children. Well, first of all, we want to make sure keep our parent in the room if at all possible when we're communicating with our children. Approach them at eye level. You want to be calm and have a friendly voice. Use short sentences, simple explanations, allowing children to handle equipment if they have to get injections. You know, uh, the doll and the pretend needle or whatnot to get them used to what's about to happen or whatnot can be helpful. Using games or drawings or things like that can be helpful or whatnot. Listen attentively. Um, you want to start with non-threatening topics when you're communicating with children or whatever. And so notice their body language, their tone of voice as well. Are they scared or whatnot? Take note of all those things. Be honest with the child. Tell the child what to expect. Okay, so when we're communicating with people of other cultures, first we need to determine what language they speak. If they don't speak English, what language do they speak? Do we need to get an interpreter to, um, to interpret for the patient? If we're using printed materials, can we get printed materials in their language? A lot of times, if you have a healthcare organization that typically sees people that speak a certain language on a regular basis, such as maybe they get a lot of Spanish speaking individuals, they may already have some materials printed in that individual's um, language, and be mindful of some of those cultural differences we talked about. Eye contact, personal space, how do they view those things in that particular culture? So be mindful of those things as well. So you're going to have to communicate with not only your patient, but you're going to have to communicate with members of the healthcare team. So that could be other nurses, physicians, dietitians, therapists, lab lab individuals, radiology, pharmacy. So all members of the healthcare team, we might have to communicate with case management, insurance companies, so and then, so there's a lot of different ways we communicate. We communicate with our notes is one way we communicate. We also communicate verbally. And when we give an handoff report, end of shift report, maybe we need to communicate with a person's transferring from one unit to the next, or we're doing end of shift report. So there's a lot of different ways we have to communicate with different members of the healthcare team. And so remember, we talked about the S bar as a way to communicate. We can use our S bar to communicate shift report, or we can use S bar when we're communicating with the physician as well. So it just depends on your facility and if they use S bar. There's a nice diagram in your book that goes through S bar, and remember I told you you can see I S bar and have that second R at the end. I standing for introduction, so you're introducing. Um, uh, you want to introduce yourself, and then if you're, whoever you're handing off report to, um, introduce your patient as well, and who they are and whatnot. The situation, what's the situation that brought us here, right? Why, what is their current condition? What's the issue or whatever? Background, what's their medical history, surgical history, things like that. Do they have any pertinent allergies or whatever? Um, Assessment, what's your assessment of the situation? What are their vitals? What, if we're calling about pain, did you assess that area? If we're calling about um, uh, brain function and what's their neural status, if we're calling about, so what's your assessment of the situation? And then recommendations, what are your recommendations? A lot of times, especially new nurses may have a fear of giving a doctor a recommendation, but it's just that, a recommendation. They don't have to take it. They can take the suggestion or not. And so, a way that you could present that recommendation, maybe say, what do you think about doing such and such? And they can say yes or no, you know. So, it's just, it's just And it's just that, just a recommendation. And then that second R, I told you sometimes you'll see that second R if you're using this S bar as a way to communicate with the physician or whatever. Read back the order. So you're writing the order exactly as the physician said, but you want to read back that order to make sure you uh, got it exactly as the physician stated. All right, so if you are calling the physician or the healthcare provider, you want to make sure you have all the information prepared and at hand. Some physicians will try to bite your head off, so you want to make sure you have everything there that you need. So, whatever questions that they may have, make sure you have your assessment completed. You can't tell the physician, hold on, let me go assess the patient. So, you want to make sure you have your assessment completed when you call the physician. Why are you calling them? Are there any pertinent lab values that physician needs to know about? Pertinent vital signs or pertinent medications. They don't need a whole list of all their medications, but if you're calling because the blood pressure is sky high, what medications are they on? What medications have they had for that blood pressure at that time? Same thing with shift report. We don't need all of our medications listed, but if there's something pertinent to the situation, maybe they're having excessive pain, then you definitely want to tell them about any pain medications you gave or whatever. Have the chart handy because maybe there's some questions that you need to look up in the chart. So have that handy in case they do have questions or whatever. Does the patient have any allergies or anything like that? And so you also want to make sure you document that call to the physician and what was the physician's response. So I contacted the physician and document what you told the physician, what you talked about or whatever, and then what the physician's response was. Did they give you an order? What was that order? Did they say just monitor? What did the physician say? And again, remember we can use that S bar to communicate with the physician. We can use the S bar for shift report, or we can use the S bar to communicate with our physician as well. So have that completed as well. So when you're calling, you'll have everything right there handy. Okay, delegation. What is delegation? Delegation is basically authorizing another individual to do something. So you authorize somebody else to do something. You assign a task um, to someone else. So as an LPN, you can delegate to an unlicensed assistive personnel. So you delegate to unlicensed assistive personnel. So that's your aides. You may be delegating to your aides. You may be delegating to housekeeping or whatnot. So unlicensed assisted personnel, and sometimes in long-term care facilities, you have LPNs as charge nurses, so you might be delegating to another LPN as well. You want to make sure when you're delegating, you're giving clear, concise messages, and you want to listen for feedback. If they say they don't understand, you want to make sure you clarify what it is that you're asking them to do and by when should we have them have this done. So be clear in what it is you want them to do, by when you want them to do. Um, know the law, know what the law says a person can do, but then also know your facility's policy when you're delegating as well, right? Because the law says an aide can take vital signs on a stable patient. However, maybe your facility doesn't allow your aides to um, take vital signs on stable patients. So your facility can provide stricter guidelines than what the law says. They can't provide looser guidelines, but they can provide stricter guidelines. So maybe they don't allow their aides to check vital signs on stable patients. So we're only assigning stable patients when we're delegating. Um, So when we talk about stable patients, an aide can feed a patient, feed a stable patient. However, remember, a patient with dysphagia is not a stable patient because they could be at risk for aspiration or something like that. So we're not going to delegate a patient with dysphagia to an aide because that patient would be considered unstable. You want to include the result desired um, of your task that's being delegated and the timeline for completing that task. Make sure your person understands how to do it, right? An aide should be able to um, transfer a patient using a Hoyer lift. However, if that aide tells you, I've never done this before, then you need to go with them and teach them how to do it and do it with them and teach them how to do it, or find somebody else that knows how to do it. So, making sure they understand how to complete the task as well. So, most of your documentation, most places that you go, you're probably not going to be able to get away from uh, using the computer to do some type of documentation. Most places have gone to computerized documentation. Um, And the computerized documentation came about initially to start preventing errors because there was a lot of mistakes being done. For example, a order was written, if an order is written and the nurse, the handwriting was not legible, and the nurse assumed that it was this amount of milligrams, but in actuality, it was another amount of milligrams or whatnot. And so instead of calling to clarify, they gave what they thought the order might have said, or you couldn't read what the lab value was, or things like that because the writing wasn't legible. So doing computerized charting or creating computerized records, that helps to prevent a lot of errors that could possibly happen in healthcare. So pretty much everything can be computerized now. So our nurses' notes are computerized. All the therapy notes, physicians' notes, all the discipline notes can be computerized. All of your orders, your physician orders, your lab results, your diagnostic test orders, your diagnostic test results, your care plans, your patient care, everything can be computerized right now. And depending on the facility, some facilities have their computerized systems set up where, um, if they have multiple locations, we can go in and access those entries no matter what location we might be at. And so, it allows easy access to patient records, up-to-date access to patient records. If the physician is at his office at the off and at one building, he can put in an order, and the nurse in the hospital can get the send it to the nurse in the hospital, and she can get that order, that computerized order. So or labs, we can get labs. As soon as the lab technician puts the lab in, we can go ahead and get that lab at that time. Sarah has just graduated from nursing school. She realizes all of the following statements are true regarding communication, except the answer is two. When communicating with a child, you should speak loudly and maintain an even tone so that the child can hear you. A child should be approached at eye level with a calm, quiet, friendly voice, not loud, not yelling, or anything like that. Speaking loudly could scare a child, and all of the other statements are true statements.